Looking at this diagram of the social determinants, I just was going to give a little detail, and then I'm going to just hand this off down the line to have people talk about, their spot on the circle or spots. So if you look at those different circles, there's one called economic stability, and people probably understand or have heard, things to do with the economic status of a person is very highly predictive of their health status and their disease burden and their longevity. So economic stability has to do with poverty, employment, food security. If you guys know what food security is people's having the confidence they'll be able to purchase enough food to eat through the course of a month. That was pretty much pioneered by Adam Junoski at University of Washington. He's done some great work on that. And also something that's been a lot in the news, and I think Seattle can be proud about, is housing stability. We had a great support for our recent housing levy. Next circle being education, and of course that is everything from early childhood education to high school graduation rates to enrollment in higher education, and the populace having the language and literacy skills to take advantage of educational systems. So each piece is very important, but the high school graduation rate's been a public health metric for years, so that because the correlation is so high between that and health behaviors and health outcomes. There's a social and community context, which has to do with things like discrimination, incarceration, civic participation, social cohesion, certainly neighborhoods that are better or significantly worse for that. That also has been in the press. There's health and healthcare access, which is probably, we were saying different analysis, 10 to 20% of the health outcomes is having to do with that, although a number of people on this panel probably spent a huge amount of their lives on that. So that's access to healthcare, primary care, and health literacy. And then there's the neighborhood and the built environment. So that's quality housing, even active communities like walkability, status of a different community, environmental conditions, crime and violence in the community, and also access to healthy food. There's this concept of food deserts, certain parts of the world where your best nutritional source is probably potato chips at the corner store, which is a bad indicator for health outcomes.
Okay, I'm Bob Crittenden. I'm with the governor's office, and I do health. But basically, right now, I'm working on health reform issues more than anything else. We have, from the state perspective, a huge sweep of impact we have, mainly through Medicaid, a lot of the mental health, substance abuse, and housing, and a number of other things. But I want to leave you with a few points. One is that we always talk about, I've lived in the world of healthcare. Healthcare is great. I enjoyed it. But after 40 years of it, it's clear that it's not enough. We really have to intercede upstream a little bit, and even though I've worked with vulnerable populations, you can move things a little bit, but you can't move the needle in a big way, and we need to move upstream. So a couple of quick points I do want to make is that there are a lot of policies out there, but implementing them is actually hard to do, and we're in the process of now doing it. We have to do it well. And so there's a lot of implementation going on, and how do we do that and make it work is a challenge. One of the challenges also, we need an ROI. The state doesn't have infinite money. It has to actually live within its means, so we really have to focus on how everything we do has to have an ROI of about 5 years. Otherwise, it probably won't be sustainable over time. To do that, though, we have to really integrate how we finance things. In other words, you save money. You may invest in, say, mental health, but when you do that, you save money in medical care. And if we don't have a way to move the funds between the two, we don't have a virtuous cycle of continued investment, and you lose the benefit of it. So we have to figure that out. And lastly, I think it's important for us to understand that this is a rare time that we're actually talking about this. I mean, we've been thinking about these things for a long time, and rarely in the state have we really had a time when we're actually having serious conversations and looking at policies and trying to implement policies that do something. And we have to be successful doing it. And I always think that we have to have good luck, and good luck for me is always the opportunity, which we have now, and it's with joined with preparation, which we really need to work at. So we have a lot of work to do, but I'd love to talk to you more as we get further.
So I'm Danette York. I am the Director of Public Health and Social Services in Lewis County. So 35 LHJs, or local health jurisdictions in the state of Washington, and out of those 35, my agency is one of about 13 to 15 that is a combined agency. So social services, or some people refer to it as human services, combined with public health. And so having that combined agency, we live social determinants of health on a daily basis. We're constantly looking for housing for our indigent population, homeless population. That's huge in our area right now. So is our graduation rates. We are actually increasing somewhat over the past few years, so we're excited about that. We're looking at, after our last community health assessment, and we're in the process of doing our improvement plan at this point, we're looking at trying to bring in higher education that is other than four-year colleges or even two-year colleges, looking at trade skills, trying to get people, the students that are not going to be moving forward to those colleges, to develop a skill, be trained in plumbing, electrical, cosmetology, those types of things, so that they can make a living wage. Like I said, we do this on a daily basis. It's very, very difficult. I'm representing both my department, which is a rural health agency, and our accountable community of health, which is a 7-county region. And most of those, at least, are either very rural or have rural areas within their counties. And so we face challenges every day that are different from those that you would see closer into the city like Seattle, but challenges just the same.
My name is Rashmi Sharma. I'm a palliative care physician at the University of Washington and a health services researcher. So I wanted to kind of give you an idea about the role of research as we think about social determinants of health. And the main takeaway, I think, is that we need more data still, and the importance of doing research in this area and generating more data. So thinking about, one, what is driving the differences that we see? So really understanding how do things like race, ethnicity, gender, education level, access to health care translate into differences in clinical outcomes. So that's one piece of it. And then the other piece is, how do we then evaluate interventions to improve and address those issues? At the end of the day, we're trying to improve the quality of care. In my case, as a palliative care physician, that's actually the quality of end-of-life care. But so how do we address the disparities that we know are translating into things like costs of care, length of stay in the hospital, quality of life, distress levels, things like that. So how do we address those issues in a way that we can measure and verify that we're actually making a difference? So that's kind of the role of research, to give us more data so that we can, one, develop interventions to address those issues, and then evaluate those interventions to make sure that we're funding measures that are going to actually make a difference at the patient and then eventually community level.
Michael Erikson. I'm the Chief Executive Officer for Neighborcare Health. I want to give you a couple of quick things about our organization, and then some quick stories to kind of illustrate some of these points of impact. Neighborcare has 28 medical clinics and school-based clinics throughout the Seattle area. We've served about 62,000 patients in 2015, 250,000 services or visits to that population. 75% of the population is at 200% of federal poverty level or less. There's been over 10,000 outreach to homeless people, and we run and manage 2 homeless clinics. And so our entire focus is reducing the access points and the disparities that access to capable primary care, dental care, and behavioral health create. So we really are on the front end, or the front line, if you will, of responding to the determinants that have created the disparities that are leading to these profound situations. There comes a point in one's career where you're doing some work and you say, wait a minute, I'm actually not living true to my values. So for me to come here to this organization, and I'm very proud of this organization to be a part of it, it's because I want to be in the space of figuring out how we address this more profound issue in our culture and our society. A couple of quick patient stories just to sort of bring this to light. Our homeless outreach workers were in a tent city, identified a man that had pretty profound sores, that the results of his diabetes that was out of control, not well treated. Figured out how to get this man, who also had mental health concerns, was very distrusting of a healthcare outreach worker, worked many days to gain enough trust to get this man to Harborview, by which a vascular surgeon was able to start the wound healing process. And imagine a nurse going to a tent to figure out how to help this man's wound heal so he could put on his shoe and go to work, which is what he had, was a nominal job from our perspective. And what did this man need? He needed a lot of help and support to try and stay in a job that eventually he could come out of that tent and get into a stable housing. All of the social determinants were at play in many ways with this one story. Pretty important. This is the front line of healthcare if you're really going to live the dream. The second story is I had a chance to shadow one of our dentists in a dental clinic. And part of this is a discipline I have as an administrator to get close to where our teams live and work, so I understand what they're responding to. Young man, mid-20s. The dentist worked with this young man. He had come to us out of a recovery center from crack cocaine addiction. The dentist said, all of the teeth in your mouth have to come out. And here's the interesting part of the story that Bob and others are helping us sort of figure out. It was going to be medically approved, and we were going to get reimbursed to take the teeth out. His ability to get dentures was nil. So there's our challenge, right? So we're on the front line recognizing these issues, and we're not complete around them. Keep a couple facts in mind as we think about this. There are while we take care of 62,000 patients, we should be taking care of at least triple that amount in Seattle through these lower points of access, meaning that we're reducing the barriers to access by going to schools, by going now to housing units where we're actually standing up clinics and housing units. We're far from having solved this problem, but well under the way, and great to have great partners with us.
Down south a little bit in our county, we work with all of our partners, and healthcare providers are definitely right there at the top of the list. And we have two hospitals. One is Providence, Centralia, and the other is Morton General Hospital. And both hospitals have representatives that come to our health partnership group, which is a collaboration of anyone that represents any agency within the county that cares about health, the health of our community. And so we work closely together to develop a core team that does our community health assessments. We try to get those collaborated to where everyone does them together at the time that we need to send in our reports on what we found. Beyond that, we have public health nurses that work with our family physicians on a daily basis, and all of our clinics for our immunization rates and et cetera. So it's just a big community for us, and we continually stay in contact. Anything comes up, any disease outbreaks, anything that each other can help with, we pick up the phone and call. That's a lot easier in a rural area. That's one of the advantages of being in a small jurisdiction, is we all know one another and we know who to call. I'm not so sure that that would be as simple here, so someone else may want to touch on that as well.
I'd like to just go up a little bit in the elevator to your question, not that you asked this specifically, but what's most profound as I've stepped into this world and this work is the importance of our legislators. So whether it be a city council member who you meet with and you say, what's it going to take to pass a city levy or a county levy around housing, those kind of partnerships to actually move this dial is profound, whether it's state level. And we have some high quality and profoundly powerful people that are trying to do the right thing here. So that really does, for me, it really is striking that it starts at this policy level. Bob represents in many ways the absolute right impulse inside a government to figure out how these funding streams that are segregated and isolated in islands between behavioral health and medical, between how you even think about housing and medical, starting to think around how do you recapture these dollars and have them actually support where you're going to have an impact is profoundly important as well. And I would say that many of our providers still are being reinforced to live in about a decade-old world relative to what this lives. And we still have a lot of work to do to get aligned, both financing and providers, because most of the providers' impulse is to do the right thing. Very, very rarely do you find a provider that doesn't want to do the right thing. But oftentimes they're reinforced and not reinforced to really think differently about this world.
And when you're at the provider level, the doctor level, particularly, you are busy, looking at the individual, and there's things that are impacting the person much more broadly. It's just really hard to do much about those, and so you rely on certain things. My first hire when I started a clinic back in '79 was to hire a social worker so we could do some things, but that's the person who did it. I mean, I didn't. And when at Harborview, when we developed a primary care medical home, taking some of your good ideas, we brought in behavioral health and everything else, but we still, those and our social worker, and they're the ones that made the contact. So, we all have our roles, but we also know that we have to be humble about how much impact we have too. It's important, necessary, but not sufficient to take good care. So I think, how do we go and reach more broadly? That's where the very difficult part of this is, and that's what we're trying to contend with. And so the state's doing some work around Healthier Washington. The counties, with their 0.1%, they're doing some very good things. The ACHs are looking at what they can do. Community health centers. I mean, one good thing right now is I think everybody's saying, well, we have a problem that we need to address, and what can we do? My big fear is that we get to a point people say, oh, we can't do any more, and we're going to stop. I think that right now everybody's leaning into it in a good way, and we have to help them keep leaning into it until we actually start making some real, irreversible progress.
This was a very interesting grant that came in, and it was between the Department of Early Learning and the Department of Health. And they were really looking at what do kids need to get the right start. They dealt a lot with this area of adverse childhood experiences, which are traumas that kids experience, and there's a very high correlation with bad health outcomes and bad educational outcomes and others. Through the lifespan, the more burden a kid has during their childhood. So, I mean, there are these little connection points, but it's been really hard to say, this investment will lead to this return because the return hits on another budget's bottom line. So I think it's really the challenge for the community to keep this viewpoint and the connection pieces in focus, and that's a challenge. So.
The Accountable Communities of Health is trying to do this. And Lewis County seems to be a little farther ahead than many of us. And what's being sought from CMS on the waiver application from the state is also trying to do this. And that is the state literally going to CMS to say, front load some dollars to us. We will not spend them in healthcare in the way they've been spent in the previous year or two. We'll invest in the kinds of things that are going to change the trajectory here, based on the hypothesis that if you change some of those trajectories, you're going to have less expenses in healthcare. Now, accountable communities in health, depending on the part of the state you're in, are a little mired down in process and not in results yet. But it's the right, absolute right impulse of the state to say, I'm going to figure out how to go get some future money that we would have otherwise spent in inefficient or less than effective healthcare delivery. I'm going to put it into outreach into housing activities. I'm going to put it into outreach to familiar faces that show up in the judicial system who actually really need treatment at a core fundamental level rather than jail treatment. So the impulse is exactly right. The execution of that is enormously difficulty, but I would say Washington is trying to do the right thing.
Through the accountable communities of health, we are trying to move that upstream as far as possible, but what is needed most of all, in my viewpoint, is data in order to show that we are making a difference and we are achieving the return on investment, which takes time. It's not a quick turnaround. We're talking years down the road is when we will really see the savings that we are trying to reach right now. And so we've got to track that data and be able to show the powers that be. Speaking from a local health jurisdiction perspective, we're at the mercy of the legislature and even our local council's current expense or general fund, that they're the ones that are funding us, or grants. So we have to really constantly keep on top of all of the data and show them what we're doing in order to continue that funding or getting some reinvestment into the prevention efforts.
So I think that we are currently generating a tremendous amount of data from all these different healthcare systems. And one of the real challenges is how we can kind of merge those data sets. So how do we really come up with a picture of how things are at a state level when you have all these different hospitals who are collecting data in different ways, who are analyzing that data in different ways. You're not able to track when the same patient goes to 4 different hospitals for admissions and really be able to understand what's going on with their trajectory. So I think it's really important with all the data we currently already have that we find ways to measure it consistently, collect it consistently across multiple health systems so that we can actually generate results that make sense for, again, at a state level or at a larger level. So I would say that I think we currently have a lot of data that can provide insight into some of those questions that we don't need to wait years for, but we just aren't doing a good job right now with managing all that data that's being collected.
I mentioned 5 years because of our 1115 waiver that we have to show savings we have to bring the trend down. So those investments that we're going to make through the 1115 most of them, enough of them, have to show an ROI. Doesn't mean all of them have to, and doesn't mean we're not going to probably look more broadly, but that's one thing. But that doesn't mean we don't think in the long term. And I think one thing that Lewis County, which I think is doing the right thing, is they're taking some of their 0.1% sales tax piece that is they can levy, and they did voluntarily, and they're putting that into screening for ACEs, for instance, adverse childhood events, which you can explain more about it because you're doing it, but that's a longer term thing. And you get some short-term benefit, but there's not a lot of money in it, savings, but it makes a huge difference in your education system and a lot of other things. So I think, yes, we have to think of the 5-year for us because we have to make sure we do that, but we also have to think of the long term. And I think the long term, you're better off if people have jobs, they have a good place to live, they're healthy families, and you can't get an ROI from everything we do. But on some things we have to if we're going to take this money and reinvest it.
And I think if you really drill it down to an individual or a family, the ROI is immediate. If you can take one person or one child and make them feel safe in a school environment to talk to their counselor, and they're looking forward to coming to school every day, that's going to be a huge ROI for that person in the long run. In the short term and in the long run. So it depends on how you look at it. Our ROI, from our perspective at this level, takes time. But if we're looking at helping the individual and the families, it's almost immediate for them.
So I want to follow up on some of the ROI discussion earlier. How much data do we have in terms of if you spend X amount of dollars in one of the social determinants, how much cost reduction do you get in the actual healthcare needed or healthcare delivered? Is there hard data there? That's number one. And assuming that data is there, I would assume the conclusion you would want is if you invest more in the earlier stages in the social determinants, your healthcare needs go down. But that's almost putting the healthcare delivery community on the other side, right? Because if you succeed,
Yes.
your need for healthcare actually goes down, which means you need fewer institutions, fewer doctors. So how does the community feel about that?
First of all, I appreciate the question, because it will need to be asked and answered at every step of the way, because our system's reinforcing the outcomes we're getting, and it's doing it at all levels. I would say what gives me hope and encouragement is a couple of things. First of all, Center for Medicaid and Medicare Services rapidly trying to say we're going to flip the equation to pay for value, which means drive from quality and service experience, and providers and practitioners and systems that are delivering that are going to be reasonably well funded going forward. The healthcare authority in the state has said by 2018 I want 60% in value-based purchasing, and they purchase a lot of health care, either through the public employees, for the public employees, or for the Medicaid beneficiaries. And so there are milestones and stakes being put in the ground to say, if we don't boldly take the system to a different place, it will not change itself. And so how these legislators align around these milestones is fundamentally important for us to start shifting the trajectory, which will allow us to make investments in other parts of the circle. So I'm encouraged that you can see those milestones. Lots of things could happen to get in the way. National elections, state elections, bills that come forward. But it's I think Bob said it earlier, it's got the positive attention, and it has to just keep moving.
Two questions. The first is, what about using the emergency department information exchange as a way to capture data across systems?
And I would add, how about using your fire departments and your police? Because they're actually on the front line of that as well. I think it's a fascinating question. I mean, first of all, it was referenced before. There is incentives now and also processes in place to get these disparity HRs to begin to link. And again, Healthcare Authority has put a stake in the ground that if you're funded through a Medicaid program, you're going to have to submit to a common data platform. It's those kinds of activities that start to move the dial. I would just say, as I've met and talked with our homeless outreach workers, I don't want to undersell the fact that our EMS system and our police systems are oftentimes the front line of healthcare here. And somebody in this room, I hope, is thinking about what's the application for a police officer to say, I have so-and-so in front of me, and that pings a caseworker's cell phone that says, I'm that individual's caseworker. Here's where we can take them, and here's how we can intervene that'll be more effective than you taking them to the jail. At some point in time, creating those kind of innovations, I don't know what the economic model is underneath it. I just know the need is huge. So one of the remarkable things here is that you don't go after social determinants of health without having a lot of partners. And more importantly, you'll see in some of the literature around this, you actually should not predetermine what the solutions are until the partners have come together with the clients, if you will, and thought through what is the next step.
Well, I just want to say one thing, and that is that we often think of health care, we think of health outcomes, but I think we're really trying to move now to say, how do we make the health, help our families have better health overall, their kids growing up, as well as the adults live longer and healthier. And we have huge disparities just on the mental health one. People with severe mental illness die 20 years or so earlier than their peers. But you look at different populations, different groups, important to bring everybody up, including people who are very well-to-do. One of the things that's important is that I think you mentioned the fact that income has a lot to do with how people do. The important thing in the United States is that our wealthiest group, our top 1/5, are actually not as healthy as the bottom 1/5 of England, which means our healthiest people are not as well. And it's not just those people who get affected by a lousy system. It's all of us. And I think it's important for us to understand that this is not just trying to be good for the poor people, but this is actually going to make a difference in all of our lives.
That's a great point. We really are in a pretty special time. Maybe it's just where I feel like I've come in my professional career, to have a city asking the question around how do we affect social determinants, to be in a state, to be in a county asking the same question, to be in a state asking the same question. I don't know of a time in my professional career or memory when that has been true. And so what we do from this point forward, again, is critically important. And the fact that you showed up to this topic would say it's on your mind too. So let's keep going forward. We're doing the right thing.
Yes, so thanks again for having me. This has been a really great conversation. I think the things I wanted to leave you with are, one, how powerful social determinants of healthcare are, that it influences health across the entire spectrum. So from preventive health through end of life, there's a role. And I can't think of that many things that have such a powerful role. So I think, one, it's wonderful to see people thinking about this. From my end, it's been great to see more and more research about this topic, and then all the way to the legislative actions to try and actually address these problems and create solutions. And I think the other point I wanted to make, when we were talking about how a lot of these circles are siloed in terms of departments and funding streams, is to think about the way, hopefully, in which research will inform us about these connections and these associations. How do these complex factors all interact with each other and then translate to the outcomes we're seeing? So I think there's a lot of work to be done, but it's great to see that we're making a lot of progress.
Well, I'd like to thank this great set of panelists. I've certainly learned a lot, and it's been really good to hear from all of you. And I'd like to thank Cambia Grove for pitching the topic, and David in particular for keeping us organized. That was wonderful.